Welcome back to the deep dive. Today, we are taking a systematic approach to what is, well, arguably one of the most common and complex patient presentations you'll see in acute care, musculoskeletal trauma.
It really is.
Our mission here is to transform this massive detailed body of clinical knowledge into a rapid, high-yield guide. We want to give you that vital, shortcut to well-informed clinical preparedness.
And for that, we've distilled the critical foundation from Chapter 37 of Brenner and Sutter's Medical Surgical Nursing textbook. Think of this chapter as your clinical roadmap. It starts with the basics, the initial assessment for simple soft tissue injuries, and then it moves all the way through casts, traction, fixators.
The mechanics of stabilization.
Exactly. And it culminates in managing those high acuity complications like compartment syndrome and even the specific care for fractures and amputations. We're really focusing on maximizing your clinical effectiveness and, just as importantly, your vigilance in preventing those life-altering complications.
That systematic approach is exactly what you need. Now, right at the top, the source material makes a really fascinating distinction about how we even talk about these injuries.
It does.
Trauma professionals, they strongly urge us to use the term unintentional injury over, the common term accident.
And that's so much more than just semantics. It's really a core philosophical position in trauma care.
How so?
Well, the term accident kind of implies that the event was inevitable, that it was unpreventable. But when we use unintentional injury, it reinforces our professional duty to look for points of prevention.
Ah, I see.
We know that primary prevention strategies, think of motorcycle helmet laws or mandatory seatbelt use, they significantly decrease the incidence and severity of these injuries. So using precise language just reminds us that our role extends beyond treatment. It goes into advocacy and prevention.
Okay, that makes perfect sense. Let's unpack the foundational injuries that often bring patients in. We can start with that core trio of soft tissue injuries. Contusions, strains, and sprains. They get confused all the time, but clinically, the tissue that's damaged really dictates the severity.
We absolutely have to differentiate them.
Right.
And it all comes down to the mechanism of injury and the anatomical structure that's actually affected. A contusion, clinically speaking, is the simplest one. It's a bruise.
Just a bruise.
Right. A soft tissue injury from blunt force. You get trauma from a blow, a fall, something that ruptures the small blood vessels. This leads to ecchymosis, that's the discoloration we see, or maybe a hematoma, which is a localized collection of blood. The symptoms are pretty straightforward: pain, swelling, discoloration. But crucially, it typically resolves on its own in about 1 to 2 weeks.
So it's contained.
Exactly. It's confined to the microvasculature and the surrounding tissue.
Okay, now let's move to the injuries that really affect movement itself. How do we clearly differentiate a strain from a sprain? Because for students, that distinction is absolutely key.
There's a simple mnemonic that can help here. Just remember, the letter T in strain is for tendon and muscle.
Okay, T for tendon.
A strain is an injury to the muscle or the tendon. People often call it a muscle pull. It usually results from overuse, overstretching, or just excessive stress. You see it a lot in the hamstrings, the quads, or the back.
And these are graded, right?
Yes, they're graded by severity. A first-degree strain is the mildest. It's a slight stretch, you'll have some gradual tenderness, but the key is the patient keeps their full range of motion.
And when do we cross that line into actual tissue damage?
That happens in a second-degree strain. Now we're talking about a moderate stretch and a partial tear of the muscle or tendon.
Ouch.
Yeah. The patient experiences acute, immediate pain, significant edema, muscle spasm, and often that bruising, the ecchymosis. And importantly, the pain gets worse when you move the extremity passively, what we call PROM, or passive range of motion.
And third degree must be the worst case scenario.
It is. The third-degree strain is a complete rupture or tear. The patient will report an immediate, violent tearing or a snapping or burning sensation, and that's coupled with a definite loss of function.
Is there anything else we need to look for there?
Clinically, when a tendon completely ruptures, you have to rule out an avulsion fracture. That's where the powerful pull of the tendon literally rips a small fragment of bone away from its attachment site. And this is a critical point. X-rays can't see soft tissue, so the diagnosis really relies on specialized imaging like an MRI or an ultrasound to confirm just how bad the tear is.
Okay, so if the T's in strain is for tendon and muscle, then a sprain must involve the L in ligament.
Exactly. You got it.
Yeah.
A sprain is an injury to the ligaments and the tendons that surround a joint. Remember, ligaments connect bone to bone. They provide that crucial joint stability. Sprains are caused by a twisting motion or hyperextension that forces the joint outside of its normal range.
Like a classic ankle twist.
A classic ankle twist, a knee injury, a wrist injury from a fall. Exactly. And just like strains, sprains are also graded. Grade 1 is a slight tear, so you get mild pain and some minor swelling.
And grade 2?
Grade 2 is a partial tear. Now you'll see increased pain, significant edema, and this is crucial, some measurable joint instability, and a partial loss of function.
So the joint is actually loose.
A little bit, yes. And a grade 3 is the complete tear or rupture of the ligament. This leads to severe symptoms and really pronounced abnormal joint motion. And just like with severe strains, grade 3 sprains can also cause an avulsion fracture, which is why we almost always get an X-ray.
So regardless of which of these 3 soft tissue injuries we have, the immediate general management is that familiar acronym RICE-E. Let's detail the mechanics of this because the timing and technique are so vital.
RICE. It stands for rest, ice, compression, and elevation. Rest is, of course, mandatory to prevent more damage. Ice is used for its vasoconstrictive effect. You apply cold intermittently for the first 24 to 72 hours, and that decreases blood flow, which minimizes bleeding, swelling, and discomfort.
And what's the critical safety rule for icing? You can't just leave it on there.
No, absolutely not. You should never leave cold packs on for longer than 20 minutes at a time. Continuous exposure can actually cause tissue damage, even frostbite.
Wow.
After ice, you have compression, usually with an elastic bandage, to control bleeding and edema. And finally, elevation. The extremity has to be positioned at or slightly above the level of the heart. This uses gravity to help with venous return and minimize fluid buildup. And often this is supplemented with NSAIDs, non-steroidal anti-inflammatory drugs, to manage the pain and inflammation.
Beyond RICE, what is the single most immediate, non-negotiable nursing priority in all musculoskeletal trauma?
It's the vigilant assessment of neurovascular status. This is the absolute cornerstone of preventing the worst outcomes.
So what does that entail exactly?
We're performing a focused assessment that evaluates both the circulatory or vascular and the nerve or neurologic function distal to the injury. We check the 5 Ps, which we'll get into more with compartment syndrome, but this includes pulses, capillary refill, skin temperature, sensation, and motor function.
And how often are we doing these checks in that acute phase? It has to be rigorous.
It has to be. The textbook mandates checks every 15 minutes for the first 1 to 2 hours after the injury or any intervention. Then it's every 30 minutes until the patient is demonstrably stable.
Why that intensity at the beginning?
Because those first 2 hours are the highest risk period for the rapid development of a hemorrhage or, more commonly, acute compartment syndrome, or ACS. We are aggressively looking for those early red flags. A decrease in sensation, what we call paresthesia, diminished motion, or a pain that is just completely disproportionate and escalating.
Okay, let's transition to issues with the joint structure itself. Let's talk about joint dislocations. These are distinct orthopedic emergencies that need immediate attention.
They absolutely demand urgency. A dislocation is the complete displacement and separation of the articular surfaces of the bones that form the joint. Then you have a subluxation, which is similar, but it's a partial or incomplete separation. It usually results in a less dramatic deformity.
So why are acute traumatic dislocations considered such an emergency? What are we fighting to save?
The urgency is all about ischemia and nerve damage. When those bones are displaced, they can compress or even entrap critical neurovascular structures, major blood vessels, and nerves. If that dislocation isn't reduced quickly, the compressed blood supply can lead to ischemia and potentially cause avascular necrosis, or AVN.
Avascular necrosis.
It's also known as osteonecrosis, which is literally the death of bone cells from a lack of blood. And that can permanently destroy the joint.
So what are the telltale clinical signs that just scream dislocation when a patient comes into the ED?
Severe acute pain is always there. You'll also notice an obvious striking deformity or a really awkward positioning of the joint. The patient's range of motion will be severely decreased or maybe even entirely absent. And then we confirm the diagnosis with an X-ray, which is critical not just to see the dislocation, but also to rule out any associated fragments that might complicate the reduction.
And medical management centers on a prompt reduction to restore that alignment?
Yes, and it's usually a closed procedure. The joint must be immobilized exactly as it's found before transport. Then, closed reduction involves non-surgical, manual manipulation to restore alignment, but this requires significant analgesia, muscle relaxants, maybe even anesthesia, because the muscle spasms fighting against the reduction are just immense.
You also touched on this interesting ethical dimension. The textbook specifically discusses the conflict of informed consent in a fast-paced trauma setting.
Yeah, this is where that clinical urgency can really clash with patient rights. The source material presents a case where a busy provider views the informed consent process for a simple shoulder reduction as just useless paperwork.
I can imagine that.
But legally and ethically, consent is mandatory. Reduction is a procedure with risks of nerve damage, vessel injury, or even causing a fracture. We have to uphold patient autonomy. This means the nurse has to ensure that despite the pain and the patient's desire for relief, the physician has disclosed the procedure, the risks, and the benefits. The principles of doing good and doing no harm have to be balanced with respecting the patient's right to decide, even in the chaos of an ED.
And once that joint is stabilized, the nursing vigilance has to remain constant.
Absolutely. The limb is immobilized with a splint or cast. Our neurovascular assessment continues every 15 minutes until stability is confirmed. And then our education shifts to rehabilitation, proper use of the device, and recognizing those red flags for complications, unrelieved pain, numbness, or increased swelling that might suggest ACS.
Okay, let's step back from those acute limb-threatening emergencies for a moment and focus on the really common overuse and stability injuries. Let's start at the shoulder with rotator cuff tears.
The rotator cuff is such a complex and vital structure. It's made up of 4 tendons: the supraspinatus, infraspinatus, teres minor, and subscapularis. They work as a unit to cover the head of the humerus, stabilizing the joint and allowing you to rotate your arm and lift things overhead.
And the tears can happen in different ways.
They can. They can be acute from a sudden trauma like a fall, or they can be chronic from repetitive impingement and just age-related tendon degeneration.
What are the common symptoms that lead a patient to finally seek care for this?
The pain can be insidious or it can be acute.
Yeah.
Patients usually describe a persistent aching pain that gets worse with movement, and significantly they have difficulty sleeping, especially if they try to lie on that affected side.
I've heard that's a classic sign.
It is. And on assessment, you'll note localized tenderness, reduced range of motion, and decreased strength, especially when they try to initiate abduction, lifting the arm away from the body.
What's the treatment path look like?
It's always conservative at first. Rest, NSAIDs, physical therapy to strengthen the surrounding muscles, and sometimes corticosteroid injections. Surgery, whether it's open or arthroscopic, is generally reserved for significant tears where that conservative management has failed over several months.
For those patients who do end up getting surgery, what's the reality of that post-op journey? It sounds long.
It's a huge commitment. Post-op, the shoulder requires strict immobilization in a sling, maybe with a supporting bandage, for a long time, typically 4 to 6 weeks. That's to allow the tendon repair to heal. The rehab phase that follows is extensive, can last 3 to 6 months, and involves rigorous, supervised PT and dedicated home exercises. Full functionality is entirely dependent on the patient's commitment to that slow, progressive regimen.
Okay, moving from the shoulder down to the elbow, we find those repetitive stress injuries known as epicondylitis.
Yes, this describes chronic pain from constant excessive motions. You see it a lot in certain jobs or sports that require repetitive forearm use. The constant tension leads to inflammation, micro tears, and degeneration, right where the muscle tendons insert on the epicondyles, those bony prominences of the elbow.
Let's define the 2 main types. They're often named for the activities that cause them.
Exactly. First, you have lateral epicondylitis, which is famously known as tennis elbow. This comes from repetitive wrist extension and supination, the motions you use over and over in a tennis backhand. Patients have pain and point tenderness right over that lateral epicondyle. And interestingly, the book notes this is about 7 times more common than its counterpart.
And that counterpart would be?
That would be medial epicondylitis or golfer's elbow. This one comes from repetitive wrist flexion and pronation. So here, the extreme tenderness is localized to the medial epicondyle.
And the treatment for both sounds pretty similar to general soft tissue management.
It is. It starts with first-line measures. Immediate rest, completely stopping the aggravating actions, intermittent ice, and NSAIDs. We only move to more reserved treatments if those fail. Corticosteroid injections are an option, but we use them cautiously because of the potential risk of degenerative effects on the tendon itself. Surgery is really a last resort.
All right, let's focus on the knee, which is probably the most commonly injured large joint, especially in active people. We need to distinguish between injuries to the collateral ligaments, the cruciate ligaments, and the menisci. Let's start with stability. The collateral ligaments,
Yeah.
LCL, MCL.
These ligaments provide that essential side-to-side stability. The medial collateral ligament, or MCL, gets damaged when the knee is struck from the side, laterally forcing it inward. The lateral collateral ligament, the LCL, is damaged when it's struck medially, forcing it outward. In both cases, the foot is typically planted and can't move.
And the presentation.
The patient presents with acute pain, pronounced joint instability, localized tenderness, and they often need crutches because they just can't bear weight without help. Management starts with Rice analgesics. Depending on the severity grade, 2 or 3, hinge brace is often used for support. And crucially, severe MCL injuries often require a lengthy period of non-weight-bearing status, sometimes up to 8 to 12 weeks, to let that tissue repair. Severe LCL injuries are often more complex and frequently require surgery.
So the nurse's role here is really expanding beyond just rice. You're preparing the patient for a long period of restricted mobility.
Absolutely. The nursing focus includes comprehensive education on using crutches or walkers and diligent monitoring for complications that come with being immobile. Chief among those is venous thromboembolism, or VTE.
DVT and PE.
Right, deep vein thrombosis and pulmonary embolism. We also have to stay vigilant for any altered neurovascular status distal to the injury, especially since they're often in a rigid brace.
Okay, next are the internal stabilizers. The cruciate ligaments, ACL, PCL. These stabilize the front-to-back motion.
Right. These are usually injured by a forceful direct blow, typically when the foot is planted. A force that pushes the tibia forward on the femur causes an ACL injury. That's the anterior cruciate ligament. A backward force causes a PCL, or posterior cruciate ligament, injury.
And there's a classic sign here that patients often report.
Yes. The classic unmistakable sign is feeling or hearing a distinct pop inside the knee joint. That sound is literally the audible failure of the ligament fibers as they snap under the tension. And if you see significant swelling develop within about 2 hours, that is a very strong clinical indicator of a tear, most likely due to bleeding from the ligament itself.
When you're treating these, the patient's lifestyle really seems to dictate the approach.
Precisely. Conservative management with rice and stabilization is always an option. But for young, active patients or athletes, surgical reconstruction is frequently the choice.
And what does that involve?
It typically involves an arthroscopic tendon graft to replace the failed ligament. The goal is to reduce chronic joint instability, which otherwise leads to a high risk of re-injury and early-onset osteoarthritis. The post-op care is demanding, though. It requires cryotherapy, continuous neurovascular monitoring, and very strict adherence to exercise restrictions to protect that new graft while it heals.
Our final knee structure to discuss are the specialized shock absorbers, the menisci.
The menisci are those crescent-shaped pads of fibrocartilage. Their main job is to act as shock absorbers and improve the fit of the joint surfaces. Injuries usually happen from a forceful twist or high-impact repetitive actions like deep squatting.
And what kind of symptoms do these injuries produce?
They produce classic mechanical symptoms. A loose cartilage flap can prevent the knee from fully extending, which the patient describes as the leg giving way. Even more dramatically, if a torn piece of cartilage slides between the femur and tibia, the knee will actually lock, preventing any more movement. This irritation also causes joint swelling or effusion. Management starts with rice, but surgical options, like a partial or total meniscectomy, really depend on the type of tear, the patient's age, and their activity level.
And finally, for this section, let's turn to one of the most debilitating soft tissue injuries, the Achilles tendon rupture. This is the strongest tendon in the body, but it has a specific vulnerability.
Its vulnerability comes from a relatively limited blood supply combined with the immense force that gets placed on it, especially during explosive movements like jumping or sudden acceleration. The rupture usually happens during the pushing off mechanism, or, less commonly, from an unexpected forced dorsiflexion.
And the patient's description of it is usually pretty dramatic.
Oh yes. They often report a feeling of being kicked in the heel or hearing a distinct popping sound. And that's immediately followed by a profound sensation of the heel giving way. The acute pain subsides quickly, but they lose the ability to plantar flex, to point their toes, and bearing weight is severely impaired. We usually confirm the diagnosis with an MRI or ultrasound to see the extent of the tear.
And there's a considerable clinical debate about the best way to treat this.
There is. The choice is really between open surgical repair and non-operative immobilization with a cast, which can last anywhere from 2 to 8 weeks. The current consensus, though, supported by rehab outcomes, it really leans toward operative treatment, followed by early functional rehabilitation. That approach has shown superior results in terms of patient satisfaction and a quicker return to their pre-injury activity levels. But the total rehab time is still significant, generally around 6 months.
Okay, now we need to transition to the actual fracture, the complete or incomplete disruption in bone continuity. This happens when stress just exceeds the bone's capacity to absorb it. And we have to remember, the adjacent structures, vessels, nerves, soft tissue, are almost always affected too.
And precise classification is absolutely essential because it dictates the entire treatment plan. Our source details many types, which clinicians often visualize using diagrams like figure 37-2. We categorize them based on the character of the break.
So what's the most fundamental distinction?
The most fundamental is between a simple or closed fracture where the skin stays intact and an open or compound fracture where the bone pierces the skin or is exposed to the outside. That drastically increases the risk of contamination.
And what about the pattern of the break itself?
We look at patterns like comminuted, where the bone is splintered into multiple fragments. You see that in high-impact trauma. Compression fractures crush the bone, usually seen in vertebrae. A green stick fracture is a partial break, where one side is broken and the other is just bent. You see that almost exclusively in children because their bones are softer.
You also mentioned two other really vital classifications.
Yes, a pathologic fracture occurs through bone that's already been weakened by disease, like osteoporosis or cancer. It happens with very little or even no trauma. And critically, an intra-articular fracture is one where the fracture lines extend right into the joint surface. These are so significant because they often lead to chronic post-traumatic osteoarthritis and require extremely precise reduction.
And for open fractures, the textbook refers to the Castillo-Anderson system. Why is that necessary?
It's a way for all providers to immediately understand the severity of the contamination and soft tissue damage. It dictates the risk of infection and the urgency of surgery. A quick way to understand it is, type I is a clean wound, less than a centimeter. Type 2 is larger with moderate tissue damage. And type 3 is the most catastrophic. It's got extensive soft tissue damage, high contamination, and it often involves an underlying vascular or nerve injury that requires immediate and complex reconstruction.
So when a patient presents, what's that cluster of classic clinical signs that should immediately make you suspect a fracture?
First, acute, unrelenting pain. It just gets worse until the fracture is immobilized, mostly due to muscle spasm. Second, immediate loss of function because the bone structure is gone. Third, a visible deformity, meaning displacement or angulation.
Are there any other signs that are particularly revealing?
Two signs I find particularly revealing are shortening and crepitus. Shortening happens in long bones like the femur because the powerful muscles around it spasm and cause the fracture fragments to override each other. Crepitus is that distinct grating sound or sensation you can feel or hear when the bony fragments rub together. And finally, you'll see localized edema and ecchymosis, swelling and bruising develop rapidly.
Emergency management sounds simple, but the execution is critical. What is the immediate, non-negotiable step a nurse takes before that patient is even moved?
Immediate immobilization. It has to happen before the patient is moved. This means splinting the joints both proximal and distal to the injury site. This prevents the sharp fragments from causing more damage to nerves and vessels, and it helps reduce the pain from muscle spasms.
And what's the assessment protocol during the stabilization?
A full neurovascular assessment must be documented before and after you apply the splint. You need proof that the act of splinting didn't compromise their circulation or nerve function, and if the fracture is open, the protocol is non-negotiable. Cover the wound with a sterile dressing immediately, and never, ever, under any circumstances, attempt to reduce the fracture or push a protruding bone back into the wound. That is the surgeon's job.
Once they're stable, the definitive medical management moves to reduction, restoring the bone fragments to their normal alignment.
And reduction has to be done as soon as possible. If you delay, the edema and hemorrhage start to harden the surrounding tissues, they lose their elasticity, and that makes reduction exceedingly difficult. We have two main routes. Closed reduction, which is non-surgical manipulation and manual traction, usually done under sedation, followed by a cast or a splint.
And the alternative?
The alternative is open reduction internal fixation, or ORIF. This is the surgical approach. The fragments are aligned to the OR and then held securely in place using internal fixation devices. Pins, wires, screws, plates, rods, like you often see in figure 37-3. Those devices hold the reduction until the biological healing process is complete.
So the end result is immobilization. What's the nurse's role in maintaining function and health while the patient is immobilized?
We are fighting the negative effects of inactivity while trying to promote optimal healing conditions. This means aggressively controlling edema with ice and elevation, routinely monitoring neurovascular status for subtle changes, and encouraging them to participate in their activities of daily living, or ADLs. Most importantly, we promote muscle setting or isometric exercises, contracting the muscles without moving the fracture site to minimize muscle atrophy.
Okay, let's look specifically at nursing management, starting with patients who get discharged home with a closed fracture.
Here, the management is all about education. The textbook details this in checklists like Chart 37-2. The patient has to understand RICE-C, how to use their crutches, home safety like removing throw rugs, and recognizing the signs of complications, especially uncontrolled pain. And we have to clearly set expectations for healing, which is usually 6 to 8 weeks.
Open fractures, on the other hand, are a whole different ballgame because of that high risk of serious infection.
The risk of osteomyelitis, tetanus, gas gangrene,
Yep.
it's really high. The objectives are simple: prevent infection and promote healing. The interventions are aggressive. 4V antibiotics and an IM tetanus toxoid shot are given immediately on arrival. Medically, the core intervention is surgical irrigation and extensive debridement, removing all the non-viable and contaminated tissue. The wounds are often managed with specialized dressings like vacuum-assisted closures or VACs and stabilized with external fixation. And for nursing, it means frequent neurovascular checks and diligent temperature monitoring to detect systemic infection early.
Fractures are such high-risk events, and Chart 37.3 reminds us of all the things that can inhibit healing: age, AVN, diseases like RA and diabetes, smoking, certain medications. Let's focus now on the critical early complications, starting with the risk of shock.
Traumatic or hypovolemic shock is an acute, life-threatening risk, especially with high-energy injuries like pelvic and displaced femoral fractures. Like you mentioned, a femoral shaft fracture can result in the loss of 1 to 2.5 liters of blood just into the thigh tissue alone. Rapid intervention involves stabilizing the fracture, volume replacement with IV fluids, and pain management.
Okay, next up is a complex, rapid-onset systemic complication: fat embolism syndrome, FES. We need to go deep into the pathophysiology here so our listeners can really grasp how serious this is.
FES is a major cause of morbidity and mortality. It happens when fat globules from the bone marrow, following orthopedic trauma, most commonly closed long bone fractures like the femur, enter the circulatory system. These fat emboli then occlude the small capillaries, acting like tiny roadblocks, especially in the lungs, brain, and kidneys.
And the onset is fast.
It's very rapid, typically 24 to 72 hours post-injury, peaking around day 2. The highest risk population is surprisingly young men, aged 10 to 40. The clinical picture relies on the classic triad of manifestations.
Let's detail that triad and link it back to that mechanism of microocclusion.
First is hypoxemia. The fat emboli clog the lung capillaries, which impairs gas exchange, leading to hypoxia, tachypnea, and potentially acute respiratory failure. Second, neurologic compromise. Fat emboli reach the brain's microcirculation, leading to subtle changes: restlessness, agitation, confusion, irritability,
Things that could be easily missed.
easily missed or chalked up to pain. And third, the distinctive sign, a petechial rash. This rash of tiny, non-blanching red spots is caused by the fat emboli occluding capillaries just beneath the skin. You usually see it in non-dependent areas like the chest, the neck, and the mucous membranes.
This brings us back to that critical quality and safety alert in the chapter.
It cannot be overstated. Any patient with a long bone fracture who starts showing subtle personality changes, restlessness, irritability, or confusion must immediately be investigated for FES. These neurologic signs can show up even before the respiratory distress. So immediate assessment includes getting an arterial blood gas, an ABG, to confirm hypoxemia. Prevention is really about immediate fracture immobilization and early surgical fixation. The treatment, unfortunately, is purely supportive: high flow oxygen, fluid management, and possibly mechanical ventilation.
Now to the most time-sensitive orthopedic emergency, acute compartment syndrome, ACS. We've referenced it constantly because prevention is entirely dependent on our vigilance.
ACS is, simply put, a perfusion catastrophe. It's a critical elevation of pressure within an enclosed anatomic compartment, that bundle of muscles, nerves, and vessels encased by inelastic fascia. Normal resting pressure is 8 mmHg or less. If that pressure gets above 30 mmHg for a sustained period, blood flow is impaired, leading to muscle and nerve ischemia, necrosis, and irreversible limb damage within hours.
And what causes it?
It's either caused by an increased compartment volume, like massive edema or bleeding into the space, or a decreased compartment size, like a cast or splint that's just too tight. The highest incidence is associated with tibial fractures.
The assessment relies on the 5 Ps, but we need to identify the single most predictive, actionable clinical insight for our listeners.
The 5 Ps are pain, pallor, pulselessness, paresthesia, and paralysis. But the most predictive symptom, the cardinal symptom that demands immediate action, is pain. It is severe, relentless, unrelieved by elevation or standard opioids, and often described as a deep, burning ache that is completely out of proportion to the injury. Critically, this pain is often made worse by passive stretching of the muscles in that compartment.
So if you stretch the toes of a patient with ACS in their calf, the pain spikes severely.
Exactly, that's a huge red flag. Pallor, paresthesia, numbness, and tingling are also crucial early signs. But pulselessness and paralysis are late, ominous findings. They suggest that profound, often irreversible neurovascular injury has already happened. Diagnosis is primarily clinical, but it can be confirmed by using a pressure monitoring device like a Stryker monitor.
Let's detail the time-sensitive medical and nursing management for suspected ACS, including that essential caution about elevation.
This is a surgical emergency. The nurse must intervene immediately, maintain limb alignment, remove or loosen any restrictive devices. That means cutting a bandage or performing a bivalve, cutting the cast in half. And here's the crucial part. You must elevate the limb only to heart level, not above.
Why is that so important?
Elevating it above the heart actually diminishes arterial inflow, which is already compromised by the high pressure. We have to preserve every millimeter of arterial pressure we can. The definitive treatment is a fasciotomy, a surgical decompression where the surgeon cuts the fascia to relieve the pressure. The wound is often left open and then closed later. Post-fasciotomy, we have to monitor for rhabdomyolysis, which can tax the kidneys.
Moving past those early acute risks, let's look at the delayed complications related to the bone healing itself.
We have the 3 unions and 1 malunion. Delayed union is just a prolonged healing time. Non-union is the failure of the bone fragments to unite at all. And malunion, which you can see visualized in figure 37-6, is when the fracture heals, but in an unsatisfactory maligned position.
What are the interventions when healing fails like that?
Treatment ranges from non-surgical to surgical. Non-surgical approaches include using low-intensity pulsed ultrasound or external electrical bone growth simulators, like in figure 37-7. Surgically, we can do bone grafts, either an autograft from the patient or an allograft from a donor to bridge the gap, combined with internal fixation. The nursing role during this is really long-term adherence support.
Let's discuss avascular necrosis, AVN, another blood supply issue that can affect the joint long-term.
AVN, or osteonecrosis, is bone death caused by an interruption of the blood supply. It's common after fractures in areas with tenuous circulation, like the femoral head and the hip, and it's also highly associated with systemic steroid use, chronic alcohol abuse, and smoking. When the bone dies, it eventually collapses. Treatment options range from activity modification all the way up to joint replacement.
And our final major complication is the challenging chronic pain disorder, complex regional pain syndrome, CRPS.
This is a rare, debilitating condition where you have chronic regional pain that is just significantly disproportionate to the original injury. The nervous system response becomes dysfunctional.
What does that look like?
You see severe burning pain, profound edema, hypersensitivity, and chaotic vasomotor changes, where the limb might cycle between being warm and red to cold and sweaty. Froning care centers on early and effective pain relief using a multimodal approach. And there's a vital safety alert here for nursing practice. You must never use the affected extremity for blood pressure measurements or venipuncture.
The rigid cast is really the cornerstone of external stabilization. It immobilizes fractures, corrects deformities, or stabilizes a joint. The chapter outlines various types, from short arm and leg casts to the extensive body and hip mica casts, and figure 37-8 often shows those high-pressure areas.
Yes, and the material choice is so vital for patient teaching and care. We primarily use fiberglass or plaster.
Let's break down that comparison. What does the patient need to know about fiberglass?
Fiberglass casts are the modern standard. They're much lighter, stronger, water-resistant, and they facilitate x-rays better. They get fully rigid very quickly, in about 30 minutes. But this curing process is exothermic. It generates heat. The patient has to be warned about the intense but temporary warmth they're going to feel.
What about plaster?
Plaster casts are cheaper and they mold better, but they are heavy, bulky, and they take a lot longer, 24 to 72 hours, to dry completely. And when you're handling a wet plaster cast, you must use only the palms of your hands, never your fingertips, because that can create indentations that lead to pressure points and skin breakdown. We also have to make sure the cast is exposed to circulating air, and we never cover it while it's drying.
And beyond casts, we have less rigid options, splints and braces.
Right. Splints are non-circumferential. They're the preferred device in the acute setting when you're anticipating a lot of swelling, as they allow for tissue expansion and they mitigate the risk of ACS. They're also easily removable for inspection. The downside is they offer less definitive stabilization. Braces, or orthoses, are usually custom-fitted for long-term use.
And nursing management for any of these devices is all about vigilance. What's the frequency of that critical neurovascular assessment once the device is on?
The assessment has to be done at least every hour for the first 24 hours, and then every 1 to 4 hours after that, always comparing the affected limb to the unaffected one. Any diminished circulation, increased numbness, or decreased motor function has to be escalated immediately.
And that relentless warning about unrelieved pain.
The nurse must never ignore unreleased pain. Pain that isn't controlled by elevation, ice, or analgesics is the cardinal sign of two imminent threats. Either a severe pressure injury forming under the cast, what we call a hotspot, or, more acutely, the onset of ACS. If ACS is suspected, the immediate intervention is to loosen the splint or bivalve the cast and elevate the limb to heart level.
We also have to actively prevent that deterioration caused by inactivity.
That's preventing disuse syndrome. The nurse has to initiate and instruct the patient on muscle setting or isometric exercises, like the quadriceps or gluteal setting exercises you see in chart 37-4, to be performed hourly while awake. These exercises maintain muscle tone and strength without moving the immobilized bone fragments.
There are three specific devastating neurovascular complications linked to the site of immobilization that students must recognize immediately, starting with the upper extremity, Volkmann ischemic contracture.
This is a catastrophe. It results from missed or uncontrolled ACS in the forearm. It's caused by obstructed arterial and venous flow. The ischemia leads to muscle and nerve death, and the patient is left with a permanent, severe, claw-like hand deformity and devastating motor impairment. Irreversible damage can happen within hours.
And in the lower extremity, we're looking out for pressure on the peroneal nerve.
Right. If a cast or splint puts too much pressure on the head of the fibula, it can injure the peroneal nerve. This results in foot drop, which is the inability to dorsiflex the foot to lift it up. This causes the patient to drag their foot when they walk. We have to routinely check their ability to dorsiflex their big toe.
And when a patient is in a large body or hip spica cast, there's a unique GI threat known as superior mesenteric artery syndrome, or CAST syndrome.
This is a very serious complication. The large cast can compress the duodenum, squeezing it between the aorta and the superior mesenteric artery. This leads to an intestinal obstruction, abdominal distension, nausea, and bilious vomiting.
So what's the nursing alert here?
The quality and safety alert is this. Nurses must monitor bowel sounds every 4 to 8 hours and report any significant abdominal symptoms immediately. Treatment involves decompressing the stomach with an NG tube, but definitive relief often requires cutting a window in the abdominal portion of the cast or bivalving it entirely.
Okay, let's move to the second stabilization device, the external fixator. This involves that metal frame secured to the bone via pins inserted through the skin.
Fixators, which you can see in figure 37-9, are fantastic for complex, comminuted, or open fractures. They provide immediate stabilization, allow for early mobilization, and offer superior access for wound care. The major disadvantages, though, are the risk of pin site loosening and infection, which can progress to osteomyelitis, and they also present significant body image issues.
So the nursing management is almost entirely focused on that specialized pin site care.
The goal is infection prevention. We elevate the limb, cover any sharp points, and monitor neurovascular status every 2 to 4 hours. For the pin sites, we expect some clear drainage and mild redness for the first 72 hours. Consensus recommends using aseptic technique, cleaning each pin site separately, often with chlorhexidine, and interestingly, retaining any crusting around the pin site if it's uninfected, as that crust acts as a natural barrier.
And the absolute safety alert for this technology.
The nurse never, ever adjusts the clamps on the external fixator frame. These adjustments are structural and strictly the responsibility of the provider or surgeon. We just continue to encourage those isometric exercises.
Our final immobilization technique is traction, using a pulling force to align and reduce muscle spasm.
Traction is primarily a short-term intervention now, usually to stabilize a fracture temporarily before surgery. Its success relies on a few mechanical principles, like you see in figure 37-10. It must be continuous. There must be countertraction, often the patient's body weight, and the weights must hang freely. They can't be resting on the bed or the floor.
Let's look at the two types, starting with the non-invasive skin traction.
Skin traction, like buccal extension in figure 37-11, is temporary and uses low-weight forces applied indirectly through foam boots or tape attached to the skin. It's often used for hip fractures before surgery to decrease muscle spasms. We have to inspect the skin under that foam every 8 hours for breakdown.
And the other type, the skeletal traction. This is the continuous method, where metal pins or wires are inserted directly through the bone. This requires much heavier weights, up to 40 pounds, and is used for complex fractures or certain cervical spine injuries.
And the absolute non-negotiable safety instruction for skeletal traction.
The nurse must never remove the weights from skeletal traction unless specifically prescribed or in a life-threatening situation. Removing the weights instantly negates the therapeutic effect and risks displacing the fracture. The patient must use the overhead trapeze, which you can see in figure 37 to 12, for repositioning to avoid using their heels and causing skin breakdown. And we encourage hourly ankle pumps to minimize VTE risk.
Let's rapidly focus on the clinical highlights of fractures based on their anatomical site, starting with the shoulder girdle. The clavicle fracture is a common one. Clavicle fractures are typically treated with closed reduction and a figure-8 bandage, like in the figure 37-13, or a sling. The crucial education point is to caution the patient not to elevate their arm above shoulder level until it's healed, but they must start elbow, wrist, and finger exercises immediately to prevent stiffness.
Moving to the proximal humerus or the humeral neck, which is common in older women.
These are often treated non-surgically with a sling and swab, as seen in figure 37-15. The number one long-term concern is preventing frozen shoulder, so early pendulum exercises from figure 37-14 are crucial as soon as pain allows, just to maintain that range of motion.
And the humeral shaft, why is this injury so significant?
Because it carries a high risk of injury to the radial nerve, which wraps around the shaft. That nerve controls wrist extension. Most of these are managed non-surgically with a splint or functional bracing that allows early range of motion of the shoulder and elbow.
Focusing on the distal upper extremity, a fracture near the elbow puts what structures at greatest risk?
The brachial artery and the median nerve. This location puts the patient at extremely high risk for Volkmann ischemic contracture, that devastating ACS of the forearm. The nurse has to be relentless in monitoring pulses, motor function, and passive stretch pain, knowing that an immediate fasciotomy is the only way to save the hand's function.
And the common collis fracture of the wrist.
This is a fracture of the distal radius, commonly from falling on an outstretched hand, and you see it a lot in patients with osteoporosis. After reduction, the nursing priority is monitoring median nerve sensation. We test this by asking the patient to confirm a pricking sensation in their index finger and their ability to touch their thumb to their little finger. Chart 37-7 outlines essential exercises to prevent hand stiffness.
Switching to the trunk. Pelvic fractures. These are highly dangerous.
They carry a very high mortality rate, second only to severe head injuries and trauma deaths, and that's due to massive internal hemorrhage and shock. Handling the patient has to be extremely gentle to prevent displacing fragments.
And what does the assessment include?
It's wide-ranging. We check lower extremity neurovascular status, the pedal pulses, and we have to assess underlying organs. Ureters, bladder, rectum. Stale fractures are managed with bed rest. Unstable fractures require aggressive stabilization, often with external fixation or even interventional radiology to control bleeding before surgery.
The most common fracture in older adults is the hip fracture.
Over 300,000 a year, and 95% of them result from falls. They're classified as intracapsular, which is the femoral head or neck and has a high AVN risk, figure 37-20, or extracapsular. Clinically, the leg is visibly shortened, adducted, and externally rotated.
What are the gerontologic considerations that complicate this?
The older adult is highly susceptible to delirium, VTE, pressure injuries, and malnutrition. We have to continue their essential home medications and monitor for secondary complications. Surgery, like an ORIF or joint replacement, is done as quickly as possible. And post-op nursing care, detailed in chart 37-8, includes continuous neurovascular assessment, aggressive VTE prophylaxis, and adherence to critical positioning rules.
What's that critical rule?
You must turn the patient only to the uninjured side and maintain abduction by placing a large pillow between their legs. Abduction prevents the hip from dislocating. We also prioritize getting the urinary catheter out within 24 hours to minimize infection risk.
Finally, the lower leg. Femoral shaft fractures are associated with massive blood loss.
Yes, 1 to 2.5 liters, leading to a high risk of shock. Immobilization is followed by internal fixation, often with an intramedullary nail. The major long-term complication is restriction of knee motion, so early knee exercises are vital.
And tibia and fibula fractures.
These are critical because they carry the highest risk of acute compartment syndrome. We have to aggressively assess the peroneal nerve function dorsiflexing the big toe and monitor tibial artery pulses. Healing is often very prolonged, lasting many months.
And a seemingly minor injury that demands major nursing vigilance. Rib fractures.
Rib fractures are common. The fracture itself isn't the main risk, the pain is. The pain causes the patient to involuntarily splint their chest, leading to shallow breathing and decreased respiratory effort. This predisposes them to serious complications like atelectasis and pneumonia.
So the treatment is about managing that pain.
It's all about aggressive pain control analgesics, nerve blocks to facilitate deep breathing and coughing, and a critical safety rule. Chest binders are contraindicated because they further restrict chest expansion. We push for incentive spirometry to prevent those life-threatening pulmonary complications.
We turn now to amputation, the surgical removal of a body part. While trauma is the second most common indication, the vast majority result from disease processes, primarily related to vascular insufficiency. The goal is always to control pain and disease, maximize function, and preserve as much limb length as possible.
And that preservation is key, especially preserving the knee or elbow joint. It's vital for successful prosthetic use. Walking requires significantly more energy, up to 60% more, after an above-knee amputation, or AKA, compared to a below-knee amputation, or BKA.
And sometimes it's a staged process.
Yes, if the limb is highly infected or gangrenous, a staged amputation, sometimes called a guillotine style, is performed first to debride the infected tissue before a definitive closure is done days later.
Postoperative care is highly specialized. You're dealing with hemorrhage, infection, contracture, and the psychological impact, including phantom limb pain, PLP.
The primary medical objective is a non-tender residual limb with healthy skin that's ready for a prosthetic. Post-op, the limb is often managed with a rigid, non-removable dressing to control edema and protect the incision.
Let's dedicate some time to PLP. It affects a huge number of patients, and it's often misunderstood.
PLP is pain that's perceived in the missing part of the limb, and it affects 60 to 80% of amputees. Patients describe it vividly, as if the foot is crushed, cramped, or twisted into an agonizing position. The nurse must fully acknowledge PLP as real pain.
And how is it treated?
Treatment involves non-opioid medications. Gabapentin, which is an anticonvulsant that's highly effective for that neuropathic pain beta blockers, and tricyclic antidepressants. Non-pharmacologic therapies like mirror therapy are also used to help retrain the brain.
Beyond pain, promoting wound healing and shaping the residual limb are critical nursing tasks.
We inspect the incision daily and measure the residual limb circumference every 8 to 12 hours to monitor for edema. And if the rigid dressing is inadvertently removed, the nurse must immediately wrap the limb with an elastic compression bandage or an elastic shrinker. This prevents rapid, excessive edema, which can severely delay prosthetic fitting.
The psychological aspect body image is profound here.
It is. The chapter emphasizes that amputation causes a significant body image alteration. Nursing research suggests the initial mirror viewing of the residual limb can be shocking, so nurses are tasked with facilitating this experience in a controlled, supportive environment, communicating acceptance and encouraging the patient to look at, feel, and actively care for their residual limb. This hands-on acceptance is vital.
And finally, let's detail the necessary positioning to prevent contracture.
Proper positioning is non-negotiable, particularly for lower extremity amputations. We must strictly avoid elevation, abduction, external rotation, and prolonged flexion of the residual limb. Crucially, the limb should not be supported on a pillow.
Why is that?
Because it promotes a hip flexion contracture, which makes a successful prosthetic gait impossible. Instead, the patient is encouraged to lie in the prone position on their stomach for 20 to 30 minutes several times a day. This provides a deep stretch to the hip flexor muscles and prevents contracture.
And the immediate life-saving measure for hemorrhage control.
Given the proximity to major vessels, hemorrhage is a life-threatening possibility. A specific quality and safety nursing alert requires that a tourniquet, clearly visible and easily accessible, must be secured at the patient's bedside. If severe hemorrhage occurs, the nurse must immediately apply that tourniquet to the residual limb to control the bleeding while simultaneously notifying the surgical team.
This has been a truly comprehensive deep dive into musculoskeletal trauma management. To really consolidate this massive volume of information for our listeners, what are the 3 most critical takeaways you want them to apply to their clinical practice immediately?
First and foremost, vigilance is non-negotiable. Early and continuous neurovascular assessment, those 5 Ps every 15 minutes initially, is the single highest priority in all musculoskeletal trauma.
Okay, vigilance first.
Second, master the ACS distinction. Acute compartment syndrome is a surgical emergency defined by pain that is unrelieved and made worse by passive stretching. If you suspect it, intervene immediately, loosen or bivalve the cast, and elevate the limb only to heart level, never above, to preserve that arterial perfusion.
That's a critical point. And the third?
Third, Recognize site-specific risks. Understand that all immobilization techniques carry distinct, specific dangers. Volkmann contracture for the forearm, peroneal nerve injury leading to foot drop in the lower leg, and cast syndrome in the trunk. Your nursing surveillance must be tailored to these risks. And remember, rehabilitation begins immediately, whether it's through hourly setting exercises or aggressive contracture prevention.
That is fantastic synthesis. You've really brought the critical clinical links to the forefront. As we conclude, we spent a moment at the beginning discussing that inherent conflict in trauma care, the physician who questioned the utility of informed consent in a crisis. This juxtaposition of life-saving urgency versus patient autonomy is profound. What final provocative thought would you leave with our listeners regarding this ethical reality?
Well, the textbook highlights that in the chaos of the emergency department, the principles of beneficence, saving the limb, preventing nerve death, and non-maleficence, doing no harm, they often seem to override autonomy, the patient's right to decide. So the ethical question we have to constantly ask ourselves is this: what deliberate, non-textbook strategies beyond the required legal ritual can nurses and ED teams deploy in that chaotic, high-pressure environment to genuinely ensure that the patient's voice, dignity, and autonomy are respected and upheld, even when we are moving at the speed of a life or limb threat?
Wow.
It's a continuous striving for ethical excellence in the most compromised of circumstances.
A truly vital question for reflection as you prepare to care for these complex patients. Thank you so much for joining us on this deep dive.
My pleasure. Be vigilant and study hard.
We'll see you next time.